Hello, my name is Kim Harford. I am doing part B of this presentation, NCD due to traumatic brain injury. The article I have chosen was Neurocognitive Predictors of Post-Traumatic Stress Disorder Symptoms in Children 6 months after traumatic brain injury, a prospective study. The authors of the study was Gal, Edmund Anderson, and Canardi. This study examines neurocognitive defects at 6 months after pediatric TBI on the development of post-traumatic stress disorder symptoms 6 months after the injury. TBI occurs when an external force to the brain causes transient or permanent neurological dysfunction. TBI occurs 20% in youth before their 19th birthday. TBI and PTSD frequently co-occur. 4% to 86% of children with a TBI will present symptoms of PTSD. Post-traumatic stress disorder is a psychiatric disorder characterized by symptoms of re-experiencing hyperarousal avoidance as a result of a distinct traumatic event. PTSD occurs more frequently following a traumatic brain injury than emotional traumas or injuries not involving the brain. This overlap in symptoms also raises questions whether any injury-related factors underline the development of PTSD after TBI. The three theories the study looked at was neurocognitive theories of PTSD. They looked at the neurobiological theory, dual representation theory, and emotional process theory. The neurobiological theory looked at the PTSD symptoms stem from difficulty disengaging attention from traumatic-related cues. Natural internal system fails, attention control is impaired. Individuals may adopt behavioral strategies to help regulate this stress arousal. When attention control is impaired, studies have shown this is a great predictor of PTSD in children. Dual representation theory is the working memories involves the ability to hold and process memories. This may affect verbal and sensory representation of trauma. Emotional process theory, PTSD symptoms stem from the disorganized fear memory network. Avoidance coping prevents the individual from learning correct information, which can prolong the PTSD. The method of the study was there was 166 children who participated in the study. The children were picked from 3 hospitals in the country of Australia. Their ages range from 6 years old to 14 years old. PTSD symptoms were measured at 6 months after the traumatic brain injury. This study measured pre-injury factors, injury-related factors, and post-injury factors. Under post-injury factors, the study also measured PTSD in the children, full-scale IQ, sustained attention, working memory, verbal learning, and process speed. Findings Findings also in this study looked at older children compared to younger children have a greater coping skills that may protect them from traumatic stressors. Younger children tend to have a greater neurocognitive defect and poor prognosis, following a TBI compared to older children. Children with mild injuries, particularly younger children and girls, may need more attention for diagnosis and treatment. Children with PTSD after a TBI may benefit from learning to help with disengaged attention distractions. More study is needed to improve earlier risk of PTSD in children. 3 websites that gave great information on traumatic brain injuries were American Speech and Language Hearing, Brain Injury Association of America, and Brain Traumatic Foundation. The research sources I used for this presentation were the DSM-5 and the article, which was the Neurocognitive Predictors of Post-Traumatic Stress Disorder Symptoms in Children 6 months after traumatic brain injury. This is the end of my presentation. Thank you.